I'm really excited about our speakers today and our conversation. I've been thinking about monoclonal antibodies since I think March 1st, when the pandemic started and the conversation began. And how much does it help? Does it help? How should we give it? Who should get it? So we're going to talk about that today because we're continuing to do it. And we have some great speakers. We have Dr. Lucy Douglas, family medicine physician who did her medical degree at the University of Washington, a family medicine residency at Ventura County Medical Center. She's got a lot of titles, but most importantly, she was in charge of the COVID response team, medical director there. So thank you for joining us, Dr. Douglas. We have Dr. Fukuta, who is an infectious disease physician. She did her training in Japan and then came here for a second medical residency, NID fellowship at the University of Pittsburgh. And she's currently assistant professor in the section of infectious diseases at the Baylor College of Medicine. So thank you for joining us. And last on our panel at the end, Dr. Tom Giordano, who is the chief of infectious diseases and professor of medicine at Baylor College of Medicine, and will be joining us in the panel discussion afterwards. So why don't we get started? I think, Lucy, are you up first? All right, take it away, Lucy.
Thank you. I'm going to share my screen. So I'm just going to talk about what we've been doing at Woodland, in the Woodland Medical Group, about monoclonal antibodies, sort of our experience more than anything, and just how things have progressed and how many folks we've treated and what it's looked like. We don't have a lot of hard data on it yet, but I'll just kind of share what we've done. We started treating, the first patient that was treated was November 21st for us, and we have continued on. So this data is through the 30th of March. We've treated 225 patients, mostly identified through our COVID response team and urgent care triage of COVID patients, high risk and early on in their disease. And we've mostly used bamlanivimab, 221 doses of that, then Regeneron, and now the dual treatment from Lilly. We started using Regeneron about a week before the FDA came out with caution or discouraging using only monotherapy. So we started using that a little bit shortly before that warning. Early on, we received 2 doses of bamlanivimab when it came out back in November. So we had this new treatment. We didn't, quite know what to do with it, who to give it to. Figured it was going to be a scarce resource. So we, through the ethics committee, decided that we would have a lottery system daily to decide who was eligible and then who would get it. Early on, we had treated patients at day 8 and day 10, and they had moderate to severe worsening symptoms after treatment. And so we kind of paused for a moment and said, what's going on here? What are we doing wrong? What did we miss? What can we do to give this to the patients that need it the most, that are going to benefit the most? And so we looked back at the studies. Back in November, there wasn't a lot of information. There was only really 2 trials, and one of them was not good and one of them was okay. And so, in the Blaze 1 trial, there was some improvement in symptoms and hospitalizations. They gave the treatment at around day 4. The median day of treatment was day 4. And then in the active 3 trial, they were treating hospitalized patients, and the median interval was around day 7 of symptoms, and they didn't do well. And they did not think that monoclonal antibody therapy was improving symptoms or outcomes in these hospitalized patients, so they stopped that trial. So we kind of sat back and said, this is a scarce resource. We only have a few doses. Who's going to most benefit is really early treated patients. So we went to only treating up to day 5 of symptoms, just because we didn't know how many we would have, how many doses we would get. And it turns out that a lot of counties around us and health systems decided not to treat with monoclonal antibodies because of the logistics of infusion. It's not easy to figure out how do you get this treatment to a patient because of the just having to have personnel to treat with IV therapy. So we got a lot more doses than we thought we would, is basically the moral of that story. And we decided we would stick to our five days. And so at this point, we've treated 225 patients, 16 COVID-related ER visits, 10 admissions, one of which was a readmit, so 9 patients, which is approximately, just doing the numbers, what they were seeing in the high-risk groups in the Blaze 1 trial, about 4% hospitalization rate. We have had 2 COVID-related deaths post monoclonal antibody treatment. We've pulled a bunch of more data to sort of compare to our community patients that were high risk that did not receive this treatment, but it's a lot to go through, and we're not really sure that we have enough information to present it here, but I just wanted to give that. We're looking to make sure that this is really something that's effective. Anecdotally, I am the medical director of the COVID response team. We call patients regularly. We call patients the day after monoclonal antibody therapy. Patients feel better. They do better. It appears that patients are improving faster after treatment. And patients really do seem to understand that the treatment now and are feeling better quicker. That's all I have.
All right. Well, thank you, Dr. Douglas. Fabulous. I think up next we have Dr. Fukuta. There you are. So, Yuriko, why don't you take it from here? And then from there, we'll go to our panel discussion. You have to unmute yourself.
Can you hear me? Oh, am I screen?
Yes. Yes.
Do you see? Thanks for having me. My name is Yuriko Fukuta. I work at Baylor Medical Center in Houston, Texas. And today I'm going to talk about a little bit of epidemiology, spectrum severity, and our monoclonal antibody experience with outcomes, and monoclonal antibody COVID variants. So as for epidemiology, so about 10% of patients with COVID do not have any symptoms, and 80% have a moderate symptom, they remain outpatient, and 10% are going to be admitted, and 5% end up in ICU. And in the United States, so far we have more than 30 million cases, and about 1/15.6 patients were admitted to the hospital. However, after vaccine was started, we see significant decrease in new cases. And this slide shows elderly people are in very high risk for hospitalization and death. And as you see, the risk to get COVID are not so different. However, as people get elderly, you see the risk for hospitalization and death really get higher. And the same as Dr. Douglas at Baylor, monoclonal antibody treatment was started, and we started in December 2020, and we had 56 cases, and most patients received bamlanivimab. And as for the risk factors are variable, and some patients are obese, some patient has diabetes, and about 17 patients had 3 or more than risk factors. So not everybody were old, so ages for ranges variability. And as for the number of patients, most patients get monoclonal antibody treatment in January. As for the outcome, 1/56 patients, 1.8% were admitted because of COVID pneumonia 3 days after the infusion. And another patient was admitted to ICU with cellulitis and sternal wound infection 2 days after the infusion, but I don't think it was related to COVID directly. and no patient was expired. So based on this, there is no comparison, but I think we can say monoclonal antibody treatment at Baylor St. Luke's has been helping patients and the community by preventing admission. But as for the capacity, how we are able to do infusion 2 patients per day in weekdays, but only 56 patients received in 3 to 4 months. So it means this treatment option has been underutilized. So I'm going to talk about monoclonal treatment for COVID-19 variant. The variants were detected in summer 2020, and there is a concern that variants may spread more easily and it may cause more severe COVID-19. And this chart shows that there is an increase in variant in the last 2 months. So this B12 is a wild COVID-19. And this B117 is a major variant in this country. And in these 2 months, it's getting more. And in this country, California, Florida, and Michigan has a lot of COVID variants. So as for COVID-19 variants and monoclonal antibody treatment, as you see, monoclonal antibody binds to a spike protein in COVID-19 virus, and by blocking a spike protein, it inhibits that the virus enter the human cells. However, the variants contains mutation in this spike protein, and the monoclonal antibody may not work well against variant. So this table shows a reduction in susceptibility for the variants. At first, for B117, it's a major variant in this country, but there is no reduction in susceptibility for any of monoclonal antibody treatment. However, in other variants, you see some reduction in bamlanivimab susceptibility. When it's combined with etesevimab, there is still reduction, but it's not so significant. About the Regeneron, there was no change in susceptibility. And this randomized clinical trial was published in February. And this study compared the changes in viral load and hospitalization in emergency room by comparing bamlanivimab combination therapy and placebo for COVID-19 outpatient. And then as for the viral load, you can see most reduction when patients were treated with combination therapy with bamlanivimab and etesevimab. And also hospitalization or ER visit rate was the lowest with a combination therapy. And then there is 70% relative reduction in hospitalization or death compared to placebo when they are using combination therapy with bamlanivimab and etesevimab. So based on this study, FDA changed the EUA from bamlanivimab monotherapy to combination therapy with bamlanivimab and etesevimab. As a conclusion, so currently FDA approved EUA for bamlanivimab etesevimab or Regeneron combination therapy, and bamlanivimab monotherapy is not recommended anymore because of concern for the variant. But based on several randomized clinical trials and experiences at each hospital, I think we can say monoclonal antibody treatment reduces COVID-19 related hospitalization, and I do think it should be offered for high-risk patients. But the combination may need to be modified because of the variant. And currently multiple clinical trials are ongoing, and the CDC is doing surveillance for the variant. So we need to follow up this result and the changes by FDA. Thank you so much.
Great. Well, thank you very much for that quick review. I realize, Gary, I better do a better job introducing Tom Giordano, because I think I messed up his introduction. Let me try it one more time, Tom. You can tell me if I'm wrong, okay? So Tom, well, first of all, he did his training at Hopkins and then Penn, and did an MPH at the University of Texas. He is the professor of medicine in ID and health services research at Baylor College of Medicine. And he is the chief of clinical epidemiology and comparative effectiveness, not the chief of ID. Is that right, Tom?
Close. I am the chief of ID.
Oh, okay, you are the chief of ID. All right, well,
It's not worth the time.
Okay.
Thank you.
Dr. Fukuta, why don't you unmute yourself and Dr. Douglas, and let's take some. I mean, I have a few questions about this, and then maybe Gary, if we have some from the audience, we can take them. But let me start by asking a little. I always have a delicate balance. I think when I came here back in November, Gary and I were like, how do we get people to start doing the monoclonal therapies? Meanwhile, not really understanding, and my background is clinical epidemiology. Tom, like yours, I'm an outcomes researcher, clinical researcher. I still wasn't convinced monoclonal antibodies help anybody at that point, but I thought, let's give it a try. The data is weak. I'm still not convinced the single therapy actually helped anybody. But yet I'm the one encouraging people to do it. So I'm going to ask everybody, where do we feel those initial therapies? And Lucy, I love the way you talked about the beginning, because we didn't know what was going on. We didn't have data. We're trying to save lives, right? So we were just trying to do the best we could. And now the data is kind of coming out. We're blaming the variants on the lack of effectiveness on the original single therapy, but maybe it just never worked. I mean, I know people feel better when they get an injection. I give B12 to patients. They love it. They feel great, but that doesn't mean it helps them. So, so that's not a helpful insight that patients, felt better. I'm going to ask, maybe I'll throw this to Tom since he's just joining us and hasn't had. So am I talking crazy here, or help me out?
No, I think a little skepticism is appropriate. The studies to date have been relatively small. They've been done quickly and fairly well. And in the middle of a pandemic, you take what you get. But the numbers of people with outcomes are relatively small in these studies, and so you're 1% versus 5% is the confidence intervals are on those numbers are fairly wide. So I think skepticism is appropriate. I do think my overall impression, I'll just cut to the chase, is that the combination therapies probably are beneficial. The problem is that there's so many people who don't need them. And it's hard to tell up front who really needs the expense and the healthcare resources that are not trivial to really maximize the yield from this. If you look at the number needed to treat, you're looking at 20 to 30 people to treat to prevent one hospitalization and about 50 people to treat to prevent one death. That's not that bad.
Not that bad, really. That NNT is not bad.
It's not.
We do we treat hypertension all day. The NNT is probably closer to 100.
Yeah, and for statins, it's a couple hundred to prevent an MI over 5 years. So the NNT isn't too bad. It's just that resources are pretty scarce when it comes to nursing.
That's the issue.
Beds,
yeah,
and that's
the amount of work it takes to give it is high. So. Yeah. So Lucy, how did you feel about that when you were doing this initially? You weren't too sure, like the evidence is not that strong, but you're going to do it anyway.
Yeah, it was really difficult decision. We sort of didn't have a lot of other things going for us, and the surge was beginning, and we wanted to at least try it. We tried to look at the numbers as often as possible, which is, I don't do data analysis and I don't have a control group, just because it worked or it showed some significant improvement in the trials. First of all, the trials had, the Blaze 1 trial had 3 different doses. And so there's kind of 3 different or 4 different outcomes. It's not very easy to compare to what we're doing. So a lot of it was anecdotal in the beginning and trying to see, is this improving anything? And that's why we're trying to look at the data now to see if we ever did make any improvement. But we also had a pretty tight knit group. We have a great relationship with the hospital and felt like we had to at least give this a shot. Because
no pun intended. Give it a shot.
Yeah. Right.
Yeah. Gary, are there any questions?
And John, if you could bring up Dr. Fukuta's deck, I wanted just to sort of probe into the table about the effectiveness with variants, but there is one question, and it is, how much does it cost? And I was actually trying to find it online as we were sitting here. I seem to recall that the drug cost was around $1,800, but I don't know if people have more information than that. But then there's all the trip to the ER and the infusion and the nursing. So see, in Woodland, do you have a feel for that? And I just to say before you answer, I think at this time it's covered by the feds because of the EUA and COVID and so forth. But what's the bill?
Yeah, I don't have a good answer for that. I think it depends on your copay for your ER visit. Those are the costs. And we certainly have had patients say, well, I can't do it because I can't afford the copay. And we've been very adamant that we're not going to turn anyone away for that reason. Right now, it is supplied by the federal government, so that the medication itself is not a cost. And there is a big concern that once it becomes that you have to pay for it, you know, what's going to happen with those patients that can't afford it, that, you know, really weighs heavy on us.
I did see last night when I was reviewing some of the literature that this is the Lilly product is one of their most profitable drugs right now. It's the single, I think it's the single highest source of income for them. The government's buying it, so
Yeah,
but it's a huge source of revenue for them.
Gary, were you trying to show something on a slide here? So otherwise, we maybe stop sharing the screen.
The table, John, it's keep going. That one. So Dr. Fukuta, oh, I'm sorry, go back one. There we go. So tell us a little more about this. So these numbers, like less than 2360 versus less than 511 for the Brazilian variant, does that mean anything, or does that the numbers are much lower, so the reduction in susceptibility, but well, I think what I heard you say is there's really not a change there.
Yeah, like this table is quite simple, but my understanding is South African origin variant shows least susceptibility against Amanita, and same as Brazilian. And in the United States, we have some, but compared to B117, the number of patients is much less. So, like last month, I think there are about 2,000 cases with a B117, but only 30 cases for Brazilian and South African variant. But in these two variants, it seems the susceptibility is much less. And then the same as circumvalescent plasma, like when we give high titer plasma, it helps these variants, but when we give low titer plasma, it doesn't help these variants. So for now, like many clinical trials with combination monoclonal therapy is ongoing, and we get to know more. But I think this variant, it's expected that the B117 variant ratio is going to keep increasing, and by the end of April, it may become more than 80%, but nobody knows.
Okay, fair enough.
So, Tom, what is that? Maybe Tom, you can help. What's the future of this therapy in your mind going forward? Like, where are we heading with this?
I think it's going to be FDA approved eventually with substantial numbers from ongoing studies. I think that I think it's all about targeting and timing and figuring out, like a transplant, a solid organ transplant or liquid tumor transplant person would be a perfect candidate for this if you can identify them early enough. Someone with on chronic steroids or other immunosuppressing drugs. I think that's where the need is going to be most acute. And once someone gets to the hospital, it's too late. So the trick is going to be figuring out how to offer this make sure that the services that see the highest risk patients know how to do it and do it well. And so I see it kind of moving into that sort of niche.
So if I'm a kidney transplant recipient and I get tested positive for COVID, I would be on a close watch to see if I progress and then maybe given this therapy.
I'd see what Lucy
Just
and
give it right
Yuriko
up
say.
front.
I'm not trying to watch. I would just say you got a transplant.
Okay.
You're on suppressants. You go.
So does that mean people like Dr. Douglas and Fukuta will eventually close shop on other COVID, or is it or do you think it's, I don't want to close your shop, Dr. Douglas, I apologize, but
At
I
some point,
guess
we all want our
eventually-
shop to close.
we do all want our shop to close. This is true. Yes, good point. Gary, are there any more questions before we wrap up?
No, there's one comment from Dr. Messer where he talked about City of Hope at Mayo treating patients with, let's see, this is my, mixing convalescent therapy, high titer antibody treatment with cancer therapy, where they were both. David, I don't know if you have any comments about that you want to mention. I'm not sure. It's on the other side of the sound barrier. So I guess the last question then would be any comments about convalescent plasma therapy and their relationship to monoclonal antibody therapy?
I think a convalescent plasma is considered to be polyclonal antibody. So compared to monoclonal antibody, they have high tolerance for variants. But I'm doing clinical trial with plasma for outpatient, but the logistic is very difficult because it's a transfusion and we need to do blood type all the time. So compared to monoclonal therapy, it's more work for everybody. So like if the monoclonal combination therapy works, it's easier for everybody. But we can say it's better to give either high titer plasma or monoclonal therapy as soon as possible for sick outpatient. Like when I say outpatient, some outpatients are not very sick, they are just coughing. But some outpatients are really sick, even they are not hospitalized. And sometimes we set up home oxygen for this patient. And for this outpatient close to admission, I think a monoclonal antibody therapy should be offered and it can be an option. But I understand because of financial reasons, some patients cannot afford and they come to clinical trial.
Well, I think we better wrap up here, Gary. I do have to say, every time I talk convalescent plasma, and I was in the middle of some of the trials, I don't think the data shows it works. So we probably shouldn't be doing it. So I think whether it's easy to do or not, we should probably not do it. The last meta-analysis, I think, was in JAMA. They said, look, this doesn't work. So let's stop trying to do this unless you're entered in a randomized clinical controlled trial. No one should be treating people with convalescent plasma. I just want to make sure we have that statement loud and clear. And I think what's interesting about this subject matter, just with vaccines, as the variants continue, we learn more, we change the therapies, we look at different ways of targeting, which makes it, both challenging but fascinating at the same time. So I guess, Gary, I'll just say thank you to everybody. Thank you to our speakers for coming, and thank you for all the hard work you've been doing this past year and pivoting and being creative, innovative, and caring for your patients.
Thank you, everybody. Appreciate it.
Thank you.
Thank you. Take care.